first program at Child Guidance Resource Centers, which is what we call our family-based program, which is what the state calls this program, the community-based in-home therapy program. I just want to shout out to everybody here who is a Family First alumni. It's really great to see you all. And I also want to acknowledge that we have what looks like a pretty big cross-section of professionals from all different parts of the system, right? There's clinicians and there's case managers, and I think there's some school counselors, which makes it a little different in terms of what you all may want to hear, and what you all may want to talk about. So I have the way I'll do it is I have some bullet points that I'll just speak off of. Maybe that will take 20 minutes or something like that, and then we'll just talk. So whatever you want to talk about, hold it until I'm through this. Then we can do either the chat or we can do the the hand raise, or however we want to do that. Okay. All right. Sound good, Leah?
Sounds perfect.
Okay. A lot of what I'm about to say is to organize myself. So when I was looking at the blurb that we put out, I thought I have to really think this stuff through again so that I can organize it in such a way that I actually understand it myself, which is really what often happens when I have to do a talk of some kind, is I have to learn it again. So what I'm going to do first is I'm going to reset for all of us and myself what family-based is for. And I'm also going to talk about what we call, internally we're calling this revising family first, right? Because we are trying to figure out how to transition from this incredibly personal community home-based intervention to this more impersonal type of service delivery mechanism called telehealth. So there are a couple things that we are on the, kind of on the cusp of learning. So I do want to describe that to everybody here to let you know that we are thinking about this, right? And we're trying to make it into a project that we're all participating in together. So for everybody here who is a referral possibility or wondering, how to consider the family that you are working with or talking to, and how to consider whether or not they are a family-based client or not, or a possibility. These are the things that I help people to look for, right? These are the lenses that I ask people to look through, which are different than, I suppose, the technical aspects of how, the criteria for meeting medical necessity and things like that, and the stuff that's sort of encoded in the language of our system. I think of this as being a little bit of a more personal, professional type of language. So the first thing is, does the family look this way? Does the child or adolescent behavior, does the family leader look unsuccessful at controlling or influencing the child or adolescent behavior? Okay, already I am asking you to look at the leadership of the family as an indicator of the possibility of a referral to family-based, okay? The second one is multiple systems and professional involvement has not yet produced what we call second-order change, right? Second-order change being the kind of change that occurs within the system itself and then can be maintained by the system. First-order change is what happens when a bunch of professionals get involved with a family and help people, right, from the angle of like a professional relationship. You guys have probably all experienced, though, how that can actually become a part of how a family operates, right? And the need to continually introduce more folks to move the case along. Family therapy is interested in what they call second order change, and that's when the change is profound enough and comes from internal to the system itself, then it can be maintained. All right, so what you're seeing there is the need for constant outside intervention that doesn't seem to ever have an endpoint to it, and that in fact gradually grows and requires even more intervention. Okay. The third thing is that the child or adolescent is what they call at risk for further behavior or emotional deterioration, right? So if you see that there isn't anything in the system that seems to be able to inhibit this movement in this direction, or as I was saying before, that the system itself does not seem able to turn this back. So you guys, as if you are referral sources or referral possibilities, you must believe or intuit that effective change would have to include family members themselves, okay? So the goal of family-based, right? There's all kinds of different elements to the mandate of family-based services as it was originally conceived, which a lot of you guys know all about because you've done it, right? But I like this one comment that I got way back in the day from one of the trainers from the training center to sum it all up. She told me that here's the quote, relationship enhancement in families leads to amelioration of mental health symptoms in all family members. Okay, this is so important and stuck in my head so well, I'm gonna say it again. Relationship enhancement in families leads to amelioration of mental health symptoms in all family members. So the goal for family therapy, pursuant to that idea, is the goal for family therapy is to help every family member become more effective at whatever their life challenges of the moment happen to be, and by situating other family members as their primary support. So when we think about a family as being in a moment of development, the developmental moment that they are in informs the therapist in terms of the needs of that moment, right? In other words, if there's an adolescent in the family, then this family is in the developmental stage of parenting an adolescent that has certain kinds of requirements that come with it. And the therapist is assessing them through the lens of how well they seem to be meeting the need of the developmental stage that the family is in. I find this kind of useful. I hope this kind of resonates with folks, only because it helps to confine the thinking of the therapist, which tends to sometimes get overwhelmed, you know, with different aspects of what the service system kind of requires them to look at or think about, or language to use and so on. But when you're meeting, you know, a family, you're meeting them at a certain moment in their time. And you're trying to identify that time as best you can as a moment of developmental, on a developmental stage. It just helps to inform what type of counseling you are eventually going to offer, because it should be derived out of the awareness of that. Now we should talk about this thing called, you know, the pandemic, right? What we're now dealing with, right, is this sense of isolation, like on top of everything that we just described in terms of the usual aspects of family struggles that can lead to a referral to family-based services, is now this thing called isolation, which is, you know, sat on everyone, including us, and I'll get to that in a couple minutes, but it has an effect now of shifting what we observe, right? So what we're looking at now is the requirement of isolation and the requirement of quarantine masking issues that may have formally brought outside attention to the family. You know, I get a couple of referrals every now and then from the family members themselves, but most of them come from a professional network. You know, in other words, this child has been known to people outside of the family. The people outside of the family are the ones who usually engineer the family's involvement in a service like this. Okay, now we're in this really weird, it's almost like a gigantic mirage, right? Like where the outside observers of a system are not really in the system anymore, or their capacity to observe is inhibited. So we're seeing this all around the system, right? I think like that calls to child line and things like that are really down. The usual mechanism of observation and involvement from the professional system is kind of like shut down to a certain extent, right? So every family now is isolated in some kind of like very, very contained environment. So we're looking at different things, right? So now family life is characterized by this as well. It's characterized now by this thing called containment, and the containment that is related to a health risk that obviously puts a lot of new pressure and stress on families, right? What people do with this kind of stress or how they manage it is one of the things that we're now trying to understand and look at, right? Because depression and a loss of hope, morale, and things like that look different family to family. They look different in different kids' age, in an age designated way. So we have a different lens that we're looking at. I try to discern this a little bit, again, outside of the language of the professional environment, and try to help people figure out what it is that they're going to look for in a way that does include this. And, besides the usual methodology for assessment, one of the things I ask people to look for is energy level. What does the energy level of the family look like? And does it appear normative given the current restrictions of family life and the ages and the membership of the family specifically? And normative means, we're actually, assessment is really when we apply a normative scale to a prospective client or family and see what parts of it are not working, right? In other words, if you have a family with a 6-year-old, I would expect a certain kind of like disruptive energy from that 6-year-old. That is not pathological. That is 6-year-old energy, right? Now I'm looking to see if that's there. I could see behavior that goes in two different directions that would lead outside of like a normative frame. One of them would be a real lack of energy, which is one of the ways that depression can certainly show up. Another one in the opposite direction would be hyperactivity and inability to settle. And I would also look at the leader of the family in terms of how they influence the behavior of the child, right? Like, are they able to influence the child? Or is there something in that mix or something in that interaction that either provokes the child or it doesn't seem to be effective, okay? So that's the other lens, right? We're looking at the behaviors. We are applying this new lens called isolation and considering its impact. And we're also looking at the leaders of the family in terms of how influential they may or may not be on these behaviors, right? So the issue of things like morale and hopefulness and energy level and things like that, we also look at the heads of the family, right? And that will probably determine, for the most part, whether or not you have a referral to a program like this or not. We also want to acknowledge that what everyone is dealing with right now is not known, in terms of, there's not a great deal of experience out there. What does mental health look like in the middle of a pandemic? We are trying to, apply what I'm calling a normative frame. I'm not even sure exactly what a normative frame is, right? So we're making this up as we go along to a certain extent. But the reason it's worthwhile just kind of sifting through all this stuff is just to bring consciousness back to the system, because the lack of of involvement that we were previously used to, right? Like the way that has kind of receded creates an illusion of, of normalcy, right? We don't see it the way we used to see it. We're not agitated the way we're normally agitated. We're not pushed on in a way that we are used to, because those are the things that would encourage us to take action. Now we're in a mode of having to kind of move in more, right? So some of us are kind of like already built for that, depending on what service you work in. And some of us like are isolated in where we work, right? So our perception is a little bit limited. So we have to become more sensitive to using whatever our lens is to start looking more closely at things like this. The last thing about what we're looking for is, how does the family's relationship with outside systems look, right? In other words, does it seem to exist in the way that it would be thought of, like where you would predict that every family would be in constant contact with their school districts, and that this relationship would be somewhat effective, you know, that the communication back and forth would be helpful. Or is it cut off, right? Or is it conflictual? Are there services that are involved in the family that we don't quite understand? You know, like, why is CYS there? What is the goal for the invitation of so-and-so into this family, and so on? So we're looking at the family from the inside, and then we're looking at the family from the outside. All of this is to say, like, to make this point that referrals to family-based are down, and they really should be up, okay? So I'm gonna like just pause on that moment, like to remind everybody that this service is up and running. You know, actually it's running in a different way, which I'll talk a little bit more about. But we are, you know, going. And all the family-based programs, as far as I know, are still taking referrals. If anybody here has questions later, you know, about how to do that, like just let me know. I'd rather you all make a referral, you know, that is even a light one, right? Because we're still more positioned to go to people, right? Like the energy of family-based, as a lot of you guys already know, is that we have the mandate to reach in, right? Not the mandate to wait until somebody reaches to us. And we still have that. We just have to do it differently now. So family-based and transition. Now I'm going to tell you a little bit about like what we had to sort of identify as the need for revising our approach, right? So, you know, I guess you've heard this comment before, like in a lot of different contexts right now, but one of the things that this crisis is doing is just shining a light on things that have, you know, previously been just like incorporated or hidden or kind of understood and assumed, right? What I'm learning and remembering now from all my years in family-based, because now once something is removed, in a sense, like how important it is becomes like glaring. All you guys who have done this before, all this family-based therapy or community-based therapy, you understand like that therapy, one of the old masters used to say that, you know, therapy started on the first phone call, okay? You guys all had the experience of how, like when you walk into that home, the minute you are invited into this home, therapy begins, right? Like you have been invited as a therapist into someone's home. I think that what happens then is the assessment for how we're going to go about the work begins in so many different ways, right? Like there's the usual sitting down and asking people a series of questions that are on the biopsychosocial and all that. And there's also the observation that you're making, just second nature, you know, by the home itself, by the neighborhood, by the way the home is sort of set up, you know. We begin to realize like I think I've used the expression in supervision from time to time, like that the home is the laboratory for the work, right? You guys are all over the place in there. You may sit on a chair to conduct your session sometimes, but sometimes you're not, you know. You're in the kitchen, you go up to the bedroom with the parents and try to get the kid to come out. You run down the neighborhood, you know, to find someone who's run out the door and things like that. Like this is, you know, this is family therapy in the home, okay? It's that. Now, we don't even think about this anymore in a sense because it's just second nature to family-based, right? Now, remove that and what do you have? So we have to figure out, like as we become more and more aware of what we're losing, we have to become more thoughtful about how to replace it, you know? So we have to figure out how to replicate this freedom of movement that we have. Like the other strength of family-based, similar to what I just described in the home, is the freedom of movement around the system, right? You're in that school meeting. You make some kind of a connection with that CYS worker. There's some kind of a case manager lurking around somewhere that you're able to connect with. You become like the center point of this family's relationship in the system at large, you know. This is all part of like the movement. I just call it freedom of movement that family-based therapists have that is hidden, right? It's not like even described that way, except when it's gone, right? And then we're kind of thinking, well, this is somehow we have to figure out how to replace this. And then the third thing is the use of this primary tool in our family therapy model, which we call enactment. Enactment is where you know, families actually practice relating to one another in a new way, in a healthier way, under the coaching of the therapist. You know, this can happen by therapist design, and it sometimes happens spontaneously, and it's a very active thing. You know, we now are doing it in a different way, or figuring out how to do it in a different way, right? Like we're doing it through a screen, like where the freedom of movement, the presence of the therapist is a physical thing in community-based therapy, right? Like you move sometimes, right? You, maybe you have had the experience, you guys would have done this, like there's an argument going on in a family that you just cannot stop verbally. What do? You get up and you walk into the middle of these two people as a way of demonstrating your absolute determination to stop them from arguing, right? So, you know, that is not a super unusual move in community-based, home-based therapy. All right, so we don't quite have that now. As we're getting used to some of this stuff, right, we're figuring out how to adapt it. This is the first thing that I thought of. We actually have some folks who have, geez, maybe they're even here today, I don't know, like who have actually done a lot of Zoom therapy. Okay, Zoom therapy is not a new thing in terms of like things like FaceTime, people doing therapy in this format. It's not necessarily used a lot, I don't think, in family therapy. I think it's usually like an individual counseling type of environment, coaching, things like that. But there is an example out there for us to learn from. So one of the things, and this was hard for the therapist in Family First, and we're still learning how to do it. They have to be much more directive in the first 5 to 10 minutes of the therapy, right? In other words, what we used to be able to count on in a kind of almost organic way when you're in the home, we have to be more directive now. That means things like the therapist scripts the first 5 to 10 minutes of a session, right? Sometimes I'll use this in supervision where I think one of the things that happens in therapy, for example, is that the therapist goes in with a plan that they work out in supervision, and then something occurs in the session that throws them completely out of the plan, you know, like the issue that the family brings up, or something that occurs in the moment makes it difficult to figure out how to apply the plan. And then the next thing you know, they're winging it again. Now, other types of therapy, in order to mitigate against this, are much more directive about the first 5 to 10 minutes of the session. This describes things like how the therapist wants everyone to sit, that the therapist is saying, I want everyone to sit in such a way that I can see you all. I also need to know where you all are so I can hear you all. So this requires like a collaboration with the parent, to help you set up the environment for the therapy session that is set before you start, right? Because this stuff gets away quickly, what we used to be able to kind of run around and retain if it went haywire after 15 or 20 minutes, we just can't do that anymore. So we're seeing how if things are not set up very clearly at the beginning, if they kind of wander off, it's harder to pull them back. I noticed this as a learning curve that's tough for some of our therapists who I think are just by nature not particularly directive, right? And much more comfortable in this just kind of moving with whatever process like they kind of walk into, which is really kind of what family-based almost requires, like you're walking into the home and you are going to kind of incorporate yourself into whatever is going on, and you get used to that. Now we have to do it in a different way, and the leadership of the session becomes much more pronounced. So that's one of the transitions that we're trying to make. And the other one is the business of how to help the parent understand how to collaborate with us. Everybody is uncomfortable, with this Zoom thing for a while, including the parent. It also goes to the nature of our clientele. We have, as you guys know, great grandparents, right, who are heads of the family. Not to just put this all into like an age definition, but how many people over 80 are particularly comfortable with Zoom? So we have to figure out how to work around all these kinds of things, right? Now, this is not to say that we're not gradually working back into face-to-face community work, right? Like this, the goal over time is to do that, but we're all experiencing this lurching back and forth, where we're opening up over here, but then we're closing up over here. We have a set of guidelines, protocols for safety that every client who asks for face-to-face therapy then goes through, and then there's a determination that is made about whether all of this can be applied, right? Like the social distancing. Do we think that the parents can affect enough distance and keep the kids with their masks on and stuff? So far we're doing a lot of this outside. Eventually, obviously, when the weather changes, we'll be hopefully moving into more inside work, but it's still going to be requiring all of these protocols. So we have to get better at sustaining a line of questioning that gives us the information that we need, right? Because we're losing a sense of the atmosphere, I guess I could say, because there's something about being in that home that is so informative. You can feel the tension, you can feel the depression, you can sometimes feel the energy, and you feed off of this like in ways that you're not even aware, I think, until you're out of it. So we have to do this now in a different way. So we're doing this more, we have to be more verbal. We have to be more directive in the first 10 to 15 minutes of the session. And I think we're all getting used to it, right? The reason I'm saying all this is to give you guys an idea of what our division is doing as an aspect of this thing we're calling revising family first, right? Like we're trying to do it in a kind of scientific way if we can. So what I've done, like we have a big division, right? So we have different committees who are appointed to make recommendations to the rest of the division. So for example, there's a bunch of people who, for whatever reason, seem very naturally inclined to do this. There's always this group of people who don't falter somehow. I don't know exactly what they do, so I need them to figure out what they do so they can tell us what they do. and help the rest of us, right? So we have committees who are, the folks who seem to be more naturally inclined to doing this have been appointed to be in a committee. They're going to give us recommendations for the rest of us, right? We also make different recommendations to add to our services, which gets me to the next point, which is taking advantage of what telehealth can do. This took a while, right, to figure out, but here are some of the things that we realized. For you guys remember, that you guys who have worked in the program remember like different like group interventions that we would put together from time to time. You know, we had a grandparents support group and things like that. And I was always proud of the fact that we could do this, partly because of how daunting it is to get groups together, right? Like, so the group intervention, which can be really powerful and helpful to people, had all these obstacles to it, right? Like travel, childcare, parking, geography, right? Whenever we were able to pull off a group, it was because we figured out somehow of a way to solve all of those different problems. So it made it was possible, and we did do it sometimes, but it was tough. All of a sudden now, it's easy. All we got to do is identify our clientele and show them how to dial in. So we've already done numbers of groups. We have an ongoing teen group. We have a parent support group. We have a father's support group. And we have something called Financial Peace University, which is a budgeting program, an 8-week budgeting program that a couple of our staff applied to learn how to do, right? It's like a franchise. So they get this lesson plan from this financial peace organization, and then we sign folks up. And they are in this 8-week program to learn budgeting and different aspects of the financial world and so on, which you can remember is a really important aspect of family life, right, for our families. So because we're a big division and we operate in like Philadelphia, Delaware County, and Coatesville, Chester County, we can now bring people in easily from all those places. So we're able to bring a group together that has no geographic line. It's easy to get a number up. We can find an easier way to get to a number of people who could really utilize this group. And then use this telehealth to bring people together in a different way. So that's an example of something that we can do. Now all we need is for managed care to give us a code that we can like build group on. I don't expect that to happen anytime soon, but that's another problem, but we can forget that one for now. So we're learning this stuff, right? What I think we'll do over time, I really think history shows us, for example, the retreats that we do, right? What we can't do now. I use that though as an experience of how we learn how to do something, and then over the course of years incorporated into our program in such a way that it became like a normal part of our yearly rotation. I think that's what's going to happen now with some of these groups, that we're going to just keep on doing them. And we will utilize like this new format to bring some things into our division that will become more part of our ongoing service delivery. So it's great that I'm able to kind of let everybody know that we're trying to do this, right? So that you know that there's a life in this division that we are learning how to utilize in a different way. Even as we continue to do our normal thing, like take these cases, these high-risk kids, apply family-based therapy, ecosystemic structural family therapy, keep kids out of the hospital when we can, take kids out of residential treatment, all the usual things. If we're attentive and we're really so far so good on that, we'll also be able to add a couple things to our division that we will retain when we someday emerge out of this and then move back into some kind of normalcy. So the last thing that I'll just kind of, nod to is this thing that we call self-care, right? Like, which is another part of what we have to pay attention to. This is very unusual situation in the sense that every therapist and family, every therapist and client sits down for a session involved in the same stress, right? There isn't the usual delineation between the client and the therapist in this particular regard, which requires the therapist to be very attentive to this, right? Like, can you help people when you are undergoing the same stress? Well, I guess the answer to that is yes, because we continue to do it. A more sophisticated question, though, I guess, is what's required for the therapist to be able to hold that position when they have to deal with their own experience, right? So first, here's just a couple things. But the first one is just the acknowledgement of this, right? Like, it's okay to not look like an expert on how to live in a pandemic, because we're kind of figuring it out as we go along. So we have these sessions with folks where we're just kind of like peers, right? We are not experts. We're not coming down from like a higher position, because sometimes therapists are kind of idealized, you know, as having this expertise and all. And sometimes we actually do. On this kind of thing, we really don't. And the benefit of that is to tell ourselves that we are okay with acknowledging that with our clients, okay? But there's other things that we have to be aware of, like that this whole thing requires that we stay alert to what the cure for isolation is. The cure for isolation for ourselves and our clients is presence, right? So every single time our therapist calls a family, even though they're annoying them with the sound of that phone 3 times a week, we think, though, that we are jarring them out of a sense of isolation, and that is beneficial to them in the long run, and so we keep on doing it. Our presence pierces isolation, and our presence requires people to engage in something outside of themselves for some period of time, and that's curative. We also need that ourselves. Okay, so in terms of self-care, every week I circulate around the division, you know, and join groups and everything, because our consultation groups now, we've got, I guess, like 7 of them, and they meet together weekly and so on. And they do case presentations. They talk about their cases in the usual way. Sometimes we talk about sociological issues of the moment. We are attentive to, you know, the racial inequality issue that is, like, you know, just arrived in such a dramatic way, and we do not ignore that, you know, in our division. So there's a lot to talk about, but also what I try to be attentive to and ask everybody to be attentive to themselves is the insidiousness of isolation in this environment requires a certain kind of attention for all of us to pay it, you know, to tune into. So we look at everybody, you know, like, I can't see a lot of you all right now. I just see your names. I see some of you, but if I saw all of you, I'd be looking, if you were my, you know, division staff, to see what you are communicating to me. And if I thought, you know, I've had the experience a few times of being a little bit worried, you know. So what I'll do is I'll reach out to that person a little bit later, for no other reason than to introduce my presence in a way to pierce what I think might be just a little bit of a sense of isolation or loneliness, right? Now, this is a prescription for all of us in the system to just kind of keep in mind, you know, like in self-care, going from the self-care angle in this particular time, we are kind of attentive to this for each other, okay? 2 more things about the self-care part of it that's related to this particular moment. One of them is called disengagement from tech. So the recommendation is to disengage from tech, right? Because this is playing on us in a way that I'm not even sure we're even aware of, you know? Like, I am like a digital refugee. Is that the term that they use? There's digital refugees and there's digital natives. as a digital refugee, I am more alert to how freaking annoying this thing can be. You know, I think the people who are digital natives may actually be more at risk because they just flow into this a little more easily. You know, but let's be, you know, aware of that because the nature of how the tech approach organizes us can be very disconcerting. You know, do you guys get like dozens of emails every day? And you understand and you realize at some point that the emails do not necessarily allow us to organize our work according to our own chronology, right? They require us to act now. They're just mechanisms, right? But they have a certain urgency to them that we may eventually pay attention to. Okay, we actually give our power and our autonomy over to this without really knowing it. So we have to pay attention to that in some kind of a way so that we retain our own agency in terms of how we organize ourselves. So this is a recommendation that I make to everybody to disengage from tech. Then we have to be attentive to this thing called working from home. Most of the therapists in our program, like, they're used to, you guys remember, you know, your day, you know, what's your day like in Family First? It's this jagged, you know, roadmap, you know, it's like Lewis and Clark. You get on the road, you have a general idea where you're going, and then it may all change, right? Like you're scheduled, but you're also responding. You're driving over here. You have to think about where you're going to eat lunch and, you know, where you're going to use the restroom. This becomes part of your day, and there's a certain adventure element to this. I think that that people got used to, right? Like, you are out there, right? No one knows what you're doing. There's a freedom to it. You tell your supervisor like what you're doing so that you can get some help. But it's really a certain kind of job that really gives people a whole lot of autonomy about how they spend their day, right? There's certain angles that your supervisors are looking at, like your productivity and, you know, how you bring things to supervision. And other than that, you know, you're pretty much on your own, right? Now you're in your home. And you're trying to like not allow like some kind of like, you don't want to get flooded, right? That means that what normally would be a natural barrier to the work, which is the end of the day and driving home, isn't there, right? Like, so you have to set up a barrier of your own, right? The setting of like a limit for your availability, or your hours that you're going to work, when you're going to be on duty and when you're not, right? Like, we've always been a program that's vulnerable to being kind of engulfed. Now we have on-call, right? And the on-call sets in at a certain time, which technically means you are off for that period of time, or at least off of the need to be attentive. So for everybody who's doing the home-based work now, you may feel some, you know, issue related to this, which is how am I going to make sure that I have some kind of like adequate division between my work life and my home life that I realize at some point requires me to decide, right? The natural barriers are pretty much gone, and so we have to be aware of the fact that we are, in a sense, too available to our jobs. It's not the kind of thing I ever thought I would say, but, you know, always being attentive to people's mental health, because we want people to feel like when they come back to their work, that they're re-engaging after some kind of a period of rest. So that is it. Those are my bullet points. At this point, Leo, let's just, open up questions or whatever people want to talk about.
Yeah, feel free to unmute or type in the chat and I can say it for you.
Let's see, I see. Okay. Right, Gabe, seeing more lower volume at the crisis center. Yeah. Which doesn't really make sense, but you know, I mean, in terms of, we certainly don't take that as a indication that crises are down. Right, we're just wondering where they're going.
Exactly. And I think also having the kids home from school is making a big difference
Right.
in what,
Mm-hmm.
you know, professionals are seeing and not seeing as far as what's going on with the kids. And that structure being removed from the kids of going to the school and interacting with other children is really making a difference in whether they're practicing regulating their behaviors or not.
Yeah. I mean, you guys know, like the yearly like routine of family based, right? Like we may have like a little lull in the middle of the summer when the anxiety in the family kind of goes down. And the biggest referral month is October, right?
That's when we have our highest volume here too. October and March.
October and March, right?
I don't know why March, but
yeah. But they're in the middle of like, you know, there's September when everyone goes back to school, and there's October where stuff has started to happen, right? And the families and the kids have all become known to other professionals and folks in the school and so on. So in terms of our yearly expectation, we don't really know. You know, if the kids are all home, like whether or not we'll see that spike in October.
So I have a question that was sent to me. You also can send it to me if you want to. What are some, I think this is what this question is asking, you can let me know if it's not. What are some signs from a Zoom screen that we should look for to identify whether a family is really in distress?
Well, the first thing is to convene everybody into the Zoom screen, right? Like I was saying, that the first, well, let me go at it this way. There has to be a certain intention that the therapist has to do that very thing. In other words, I'm going to do an assessment right now of everyone's mood. In order for me to do that, I need to see everybody, and so I will have a certain set of questions available that are age appropriate to just get a sense of everybody's responsiveness. Then I'm going to want to know, and this is the family therapy part that comes in, is how are these things influenced by other family members, right? Like I want to know how the parent does when the kid is talking, or perhaps the kid is unable to talk, or looks depressed and looks nonverbal. And if I ask the parent to help the child to verbalize, are they effective at that? Right? In other words, we think of depression as a systemic thing, and that we're looking for how family members influence one another, either to come out of it or to become more depressed. Right? If kids are not met with responsiveness, well, where are they going to go with it? Right? Like, so we're going to specifically want to assess that by putting them on the Zoom screen, and then by asking them certain questions that will bring about an observation that helps us to determine that. I mean, that's a really good question, and it's an ongoing figure out type question, you know. For example, I would have to ask our group if they've ever done this. Like, have we ever asked, you know, the kid to pick up their laptop and show us their room, right? Because we kind of like to see that stuff, you know. Like the home environment is a replication in some ways of like the internal environment, isn't it? You know, like we want to know, for example, like, do these kids have some sense of like privacy that's age appropriate? You know, do they have a place to do their homework? Is the family home set up in such a way that it actually makes it almost impossible for an individual to focus? And you guys know, like, because you've used family support funds to buy dividers and little desks and things like that, like, you know, where our environment becomes a place for the intervention, right? We have family support funds and we use them for things like this. So this requires an observation that would not be available to us unless we specifically ask for it, right? So what it tends to go back to is a sense of intention on the part of the therapist to do that, right? I want to see your house. I want to see how everybody operates. I want to know how the flow is room to room so that I can help.
Thank you. We have a question that I think we'll leave two, but I'm going to read the second one first. Do you get the impression that families are hiding the CNIP more than before, or putting on a show because they're on a screen?
I don't think that they're I don't think that they're consciously putting on a show. There's ways to evoke an observation of a family that can be genuine. I mean, family-based in terms of its clinical thinking is no different than any other therapy, which is that people have to want to be helped. You know, there's no reason to come up and to show up for a therapy session and then fake it. In any therapy, right? Like, it doesn't necessarily mean that people don't need assistance to uncover the parts of their lives that are painful or that are unseen by them. Okay, so I don't think any family shows up to put on a show. But what they do is they will play out their methodology of how they survive, right? They'll show you the way they operate. The therapist will see sometimes in what is in that has become like obscured to the family, right? In the system itself, you're just operating under your usual imperatives, like you're just reacting. It's not a fake, but it is something that binds people. What they need from the therapist is some kind of an outside observation that eventually can show them different options that they cannot see themselves.
Thank you. Can you share a little bit more about what family-based looks like right now? Is there an estimated percentage of the work that's done in person versus on video?
Yeah, well, the in-person work is, I'm not sure what the percentage is. It's probably pretty low. We expect it to get bigger, you know, certainly as time goes on and, you know, things kind of open up a little bit. It looks like the primary delivery service now is the telehealth one. I would say that was primary. There's all kinds of anecdotes around the division of what people are doing to make contact with people. They're driving over to the house. They're participating in these wave-by parties. They're picking up food at the Giant and delivering it to people and talking to them from the sidewalk. They're setting up sessions in nearby parks and things like that. So there's the usual, the therapists are like, you know, they're chomping at the bit, you know, like to kind of get out there, like, because I think that's what they're used to doing. And then the whole thing is kind of holding them back to a certain extent because they have to go through a bunch of protocols for themselves and for the families, and they all have to be in place, right? So the percentage of face-to-face is kind of low, and it's going to get bigger.
Great. I'm going to hold the space for a couple more questions if we have them. I know we're getting close to noon.
So don't forget to make a referral to family-based if you are thinking about it, okay? Don't hesitate.
So Mike, the thing I think that I'm hearing overall is that, like, right now in all of this dark, murky unknown, or maybe it's not dark, it's more like misty, right?
Yeah.
Of what's going on. It's not like we're in the night, we're just in a fog.
Yeah.
that it makes sense then that just as we've had to shift some of the rules around which we do therapy, like we do it on a phone, we can't guarantee that there's no one in the room. We sort of hope and expect. We can't, we can maintain our end of HIPAA, but we can't necessarily, like there's a lot of sliding scales. And I feel like that also has to go for referrals, that both for family face and also to Gabe's program. Like I know that I'm in private practice now, that I find myself encouraging families that typically I wouldn't make a referral to those kinds of programs. So like to take that step, and better to push them to go to get that activating energy out, to look for a higher level of care, because they can always not meet criteria. And then at least there's the therapeutic good that comes from having activated a family to acknowledge they're having a really hard time. I'm thinking like, I think that's true for both Gabe's program and your program. I don't know if I feel about a 14-hour sit in a crisis center, but certainly a Bryn Mawr stay. You know, that those things, that there's a therapeutic value in considering for a family, oh, things kind of suck right now.
Yeah. And I'll tell you something also is, since this whole thing started, we have not had any denials from any of the managed care companies. Not one. So, you know, not that they have like lowered the criteria necessarily, because it still requires like a psychological or psychiatric, but they're looking to get help for people. And if that means that maybe families that would formerly have done all right in outpatient but can't do outpatient now come to us, they are not going to block that.
I want to add to that from the Philadelphia Crisis Center perspective. CBH actually is not doing any pre-certifications to authorize service. So if our psychiatrist or our team has recommended a service, they are giving the service to the children without a question, whether it's an inpatient stay, family-based, a partial hospital program.
Right.
So I think, yeah, they want to provide the services at this point in time for folks.
Yep.
Well, I know we are about 30 seconds to noon, and just like I like to start on time, I like to stop on time. So Mike, any final words or thoughts that you want to share?
Just to email me with any other thoughts you guys might have. And certainly if you have any questions about referrals, make sure you reach out. Okay, I'm always available to talk about your case. Usually it starts out with like, I have a case and what do you think? You know, and I usually say yes, go forward with it. But I'm happy to, you know, just discuss that if you're wondering about that. And if you need help in how to navigate through it as well.
Thank you. Well, thank you all so much for joining us. We know this is such a, I mean, I was just making fun of all the marketing ads that say unprecedented time, but I'm going to say it, it's a very unprecedented time. So thank you for being here. We hope this was thought-provoking and helpful. I will be following up with contact info in case you have any follow-up questions, as well as a referral sheet if you're in Pennsylvania and you want to know how that process can work. But again, you can always just reach out to me or Mike, and we're here. And thank you for joining us today. I hope you have a good rest of your day, everybody.
Really nice seeing all you guys. Okay, have a good day.
Bye, all.